Can you see the screen? See my slide or?
Yes, I can see the first one there.
Okay. Good morning, everyone. My name is Radhe Raghavan. I'm a consultant obstetrician and gynecologist. I work at Warwick Hospital. So thank you, Elaine, for inviting me to talk to colleagues here. I was aiming to look at the audience and to see what background we are all from, but I didn't have a chance as I was operating this morning. Anyway, in the half, I'm going to be talking to you guys about trauma in obstetric patients. This is something that is extremely rare, luckily. In my consultant career for the last 6 years in Warwick, I've only had a chance, which is good, to see a trauma in obstetric patient just once. But obviously, it is more common if you're working in a bigger unit. So what I thought was, obviously, I was not sure that we wanted to, we would have had a probably concept of primary survey and secondary survey and all that spoken by my other colleagues, I would have thought. So I wanted to actually concentrate more so in the next half an hour just to talk about what is specific for pregnancy. So how the concept adapts to pregnancy. And as I said to you, in the one case that I was involved in, there was lots of human factors that actually comes in play for in the patient care. So I thought I'll just talk very briefly on that, and then the importance of effective communication in managing such patients. So I do teach in the MOE courses, even though I haven't been for the last 2 years, but what we say there is, obviously, with regards to multi-trauma in obstetric patients, in general, the results of resuscitation is sometimes not as good, unfortunately. This can be because of various factors. It could be patient-related factors, and also difficulty with the resuscitation itself. That can be a problem because of pregnancy itself. Also, there is this maybe sometimes a bit of an anxiety about having to deal with 2 patients at a time, if you like. You have got a baby inside who also is in the back of your mind as a concern that you will want to address. And there was a little bit talk in some of the case studies that we have in the EMBRACE report, which is the national report for obstetrics and of maternal outcome and morbidity and mortality, basically. And there was a case where there was a little concern about cross-specialty working or MDT input in the timely manner. So when we are talking about a pregnant patient, we would normally never call a patient in our department a patient. We would only call her as a woman. But obviously, we are talking about a trauma, and hence we would refer to the pregnant mother as a pregnant patient. So what is important here is to understand the physiological changes that happens in a normal pregnancy. Especially the more advanced the pregnancy is, the more profound those physiological changes can be. And obviously, it is extremely important that we keep this in the back of our mind, because this will have implications to the way we assess and manage such patients. If I was to teach my trainees, I would just put this slide and I would let my trainees talk me through what are the changes that they know of that happens with regards to airway, breathing, and circulation, and also the GI tract. It is relevant because all of these will have implications for resuscitation. So for the purpose of this talk, I will just move on to the next slide, where I have just put in a few salient changes that we should be aware of. For example, if we are talking about the airway, there is in general some venous engorgement and mucosal edema that can be a normal physiological adaptation or change in pregnancy. What that means is that when we are trying to intubate patients who are pregnant, that can be potentially sometimes more difficult. So that is to be anticipated. With regards to breathing, then there is increased tidal volume in pregnancy. The oxygen consumption is increased. There is the splinting of diaphragm because of the heavy pregnant uterus pressing on the diaphragm, so causing some mechanical effect on the diaphragm. So all this together means that the oxygen requirements for the mother is increased, and also it can be a little bit more harder to ventilate a pregnant mother because of these physiological changes. With regards to circulation, then there is physiological increase in the heart rate up to 16% is normal in a pregnant mother. And the cardiac output also increases because in general, the blood volume increases in pregnancy. There can be a physiological anemia in pregnancy. And because of this increased circulatory volume, and also what is also important is to keep in mind the pregnant uterus, which can press on your vena cava, and hence the aortocaval compression needs to be released or kept in mind when we are doing or dealing with a pregnant patient. So all this has got implications in the form of how the hypovolemia can present to you. Obviously, getting IV access can be sometimes difficult, and you will also need to keep in mind the lateral tilt that you need to be giving so that you dislodge that aortovenal compression. So these are usually, I'm just saying usually because majority of the times they are young, fit women, or may not be fit, obviously, depending on the comorbidities, but usually they have got good cardiovascular reserve. So they don't manifest with the signs of hypovolemia till it is very late. So I think it's vital to be able to identify the early signs of hypovolemia in these pregnant mothers and to intervene as appropriate. And with regards to the GI tract, obviously there is the effect of the progesterone pregnancy hormone. There can be delayed gastric emptying. There can be relaxation of the cardiac sphincter. So what this means is there is more likely that this mother can regurgitate. So you will need to protect your airway extremely carefully. And this is something we are always aware of whenever we give a GA to our pregnant mothers for any procedure. So just like in any, that is specifically about pregnancy and physiological changes. But in general, when you approach a trauma patient, whether she's pregnant or not, you would always approach with this primary, with this kind of a structure, which obviously I'm sure may have been touched upon in a previous talks, I would have thought. So the primary survey, obviously, follow the ABC. Resuscitation, you have to deal with the problems as you find them. Follow again ABC structure. What is important in pregnant mothers is, however, also to keep in mind that there is another patient inside this patient. Depending on how far the gestation is, that baby could be potentially viable. So that is another thing that you will probably want to get your obstetric colleagues in to deal with the threat to the life of the fetus. And it's not just only about the fetus. Obviously, sometimes evacuating that uterus can improve your outcome for the mother. I'll come to that in a little bit later. But again, that is the only thing I've highlighted in a different color because that is one thing which we would be, in addition to everything else that you would do in a trauma patient. Obviously, once you have stabilized and all that, then you have the secondary survey, which is very similar to non-pregnant patient. And then your definitive care, which is where you might want to involve your specialty colleagues to see if there was any intervention required specifically for pregnancy. So even though we have said there is another life inside this patient that you're seeing, but the best way to resuscitate that life is actually to look after your mother and resuscitate her, because the baby is actually dependent on the mother. So the moment you resuscitate your patient, it automatically improves the outcome for the fetus. So its usual teaching would be to just follow the usual ABC approach that you would take, and then obviously keep in mind the compression because of the especially in advanced pregnancy, and that is how you would deal with a pregnant patient. So if you come across a trauma patient who is looking apparently lifeless, if that is the scenario you are placed with, when you are thinking about instilling an CPR drill, obviously you will follow the rapid progression through the ABC approach. So the successful resuscitation depends on the early access to emergency service and very correct BLS, early defib, and early advanced life support. This is where you want to, you will need that multidisciplinary approach to trauma. So when you're dealing with a pregnant patient, it's normal that we teach or we are taught to say, hello, Mrs. Tilt, how are you? When you're actually approaching that only to remind us that, yes, you need to make sure that it is the one different thing that you would do is to go and put in something as a wedge behind the back so that you reduce that iotibial compression. And then the other primary assessment would be like any other non-pregnant patient: look, listen, and feel, and then you act accordingly based on what you find. So we said about hypovolemia, the signs of hypovolemia in pregnancy. Because these are pregnant patients are usually good in concealing the hypovolemia in early part, really. So you could fail to recognize that unless you know these early signs. That's where you would want your obstetric colleagues to pick up certain signs, which we are actually we are well versed in learning all these early signs of hypovolemia, because we deal with not trauma patients often, as I said in the beginning, but we do deal with hypovolemia quite often in labor ward in pregnant patients. So if I was to come in and if I found that tachycardia, if I was relying on tachycardia as a sign of blood loss, then I'm actually, I might have missed almost liter to liter and a half before actually there is maternal tachycardia that comes. So the learning is if a baby is of a viable gestation, the earliest signs of hypovolemia would be that the baby will show you the signs of being distressed, because when the mother is not well, the placentofetal circulation gets compromised. That's the first thing that could happen, and hence the fetal heart abnormalities could be very, very early on that you might be able to pick it up. In addition, obviously, there are other signs of hypovolemia, which you will find in other non-pregnant population as well, including the capillary refill, pallor, cold peripheries. But as I said to you, if we are waiting for these signs, then sometimes we might be waiting for too long, really. It may be a late sign in pregnant patients. Diastolic blood pressure usually goes up sooner. The mother can be tachypneic, oliguria, and the blood pressure falls. As I said, blood pressure falls would be really extremely late. So you might see that actually the diastolic blood pressure goes up and the pulse pressure narrows before actually the blood pressure drops. So that is almost when the mother has lost half a volume of the blood. That's when you will start to see that. So with the pregnant population, as I said to you, they can lose up to 35% of the circulating blood volume before you can find any obvious signs. So you need to have a high index of suspicion. So especially you need to be aware of how the trauma happened. Is there a likely possibility that there could be some hemorrhage that is concealed? What I'm talking about is the retroplacental hemorrhage, and that can be concealed even without trauma. Actually, sometimes we do find that actually mother comes in with some other symptom, and we might actually put the baby on the monitor, and we might find actually the baby is showing some signs of not being happy inside. And then when we deliver that baby, we find that there was hemorrhage behind the placenta. So that placenta hemorrhage is becoming concealed because it's a kind of an elastic structure, the placenta, and hence it expands and very nicely conceals that blood clot behind it. And once the once the placenta retracts more than 50%, that's when it can be life-threatening for the baby. Obviously, it also depends on what's the baby's baseline reserve as well. But in general, that was what we would be telling. So that's what we mean by saying the fetoplacental unit. So if you have a viable baby, and if you listen to the baby's heart, once you obviously stabilize the mother, and if it is showing you abnormal signs, then it's more likely that there is some kind of an hemorrhage, and for which you need some kind of an intervention to stop that, to be able to resuscitate your mother safely. So obviously, if there is no circulation, start CPR would be routine teaching for any trauma. IV access and take bloods, we would find sometimes it is quite tricky to get IV access in pregnant mothers, especially when they have lost a little bit of a blood. So that's where you need your senior colleagues and experts in to help us with that. And restore volume, and you may want to think about the compressible bleeding, which is what I was saying to you earlier, and stop the bleeding as early as possible. And that may mean that the pregnancy may need to be interrupted, which means that unfortunately you may have to do termination, like by a cesarean section, to, if the baby is obviously not in a viable gestation, then that may have to be compromised for the sake of the mother. So continuous reevaluation stands for any trauma patient, as it would with the pregnant population. So CPR in pregnant population in general is considered to be difficult. Sorry, I was meant to take this animation off. Sorry about that. So why is it difficult in CPR in pregnant patients is because we talked about the physiological changes. All this becomes extremely relevant when you're actually trying to do a CPR in a pregnant woman. So the increased oxygen demand is more. There is increased risk of aspiration from the stomach into the respiratory tract. This rescue ventilation can be more difficult. Your lung capacity is reduced. Your venous return is reduced, and overall your CPR can be less efficient. Especially, I'll tell you in a little bit later. I have had a experience of dealing with a mother who was not trauma specifically, not relevant to this, but when I'm talking about CPR, that was extremely relevant because a mother collapsed with us when she was advanced gestation, and CPR had to be instigated. And obviously, when we reviewed the whole case, unfortunately, that outcome was not good, and the mother died. This I'm talking about when I was a senior registrar just before I got the consultant job. So when we actually relooked and had a debrief about the whole thing, actually, this mother had very big, massive boobs, and obviously it was very, very tricky to get IV access, very tricky to get the chest compression. So overall, the CPR was less efficient in her case. So that is I'm just talking about that in my particular experience, but that is what is documented in lots of publications as well. So you will need to adapt to CPR in pregnancy by providing this left lateral tilt, which is why we always talk about hello, Mrs. Tilt, to remind ourselves. And you may want to resort to early intubation, and that again, as I said, can be tricky. So you will need your experienced anesthetists to try and help us with that. And again, emptying the uterus for the sake of maternal resuscitation needs to be considered. So this is not for the sake of the baby. So you're not considering how what the gestation is the baby going to be viable and all that. So this we are talking about when we are actually worried about mother and you want to improve the outcome for the mother. You may need to do what we call as a perimortem cesarean section, which unfortunately I've had to do on one occasion in my career. So it's really not where you want to be, but it does happen, and it's something that we need to kind of learn in theory, at least, so that we are prepared for worse. So what are the indications? Why would we want to do a cesarean in a pregnant mother when we are trying to deal with resuscitating a trauma patient? So that would be because the mother has not responded to your CPR and you have adapted or kept in mind all your difficulties, and you have done an effective CPR, but still mother has not responded. That's when you want to think about cesarean section. if there was to be a multi-trauma where they are taking a mother for a laparotomy, suspecting other abdominal trauma, as you would imagine, the uterus can be hamper the exposure to the other organs because it's occupying the most of your abdomen. And in that circumstance, again, you may have to do a cesarean or deliver that baby to be able to get adequate exposure and do what else needs to be done for the other trauma. And if you have a uterine rupture, which again can happen. We had a mother who had a car hit her from behind. She came in, luckily did not have any other obvious trauma. She came to A&E, was seen there and was sent up here. And what we could assess her was straight away, there was some signs of fetal heart concerns. So we took her to theatre straight away and we found that the uterus was ruptured. So if there was no timely intervention with delivery, then potentially we could have lost the baby and the mother. So that is one thing that we need to think when we are dealing with pregnant mothers. Even if it was a trivial trauma, sometimes the uterus can rupture, your placenta can abrupt. And again, the placental abruption, as I said earlier, can have serious consequences for the mother as well as the baby. Sometimes we may have an unstable pelvis or some fracture in which a mother is after a trauma. And in that circumstance as well, you may need to deliver the baby to relieve the pressure in the pelvis and let the other specialists deal with that unstable pelvis. But we need to make room for that. So perimortem cesarean, as I said, I have had to do that on only one occasion, touch wood. It's not something that you see often. So you have about 5 minutes after you've started CPR, and obviously if you're thinking that the mother is not responding, that's when you may want to do that. In the techniques that we learn, and if in the Boyer course and all that, we do say that choice of incision is midline, but it's entirely up to the surgeon, really. If you ask me, when I did it, actually, I just went in fen and still because that's what we are used to doing every single day. So whatever is a quickest way to deliver that baby and get that pressure off the uterus, off the mom's aorta. So the quickest, whatever is quickest. So if you have not done midline incisions for cesarean sections often or routinely, then you don't want to try and do that just because that's what is recommended. So the basic idea is to try and go as quick as you can. And throughout this process, when you are doing this as an obstetrician, you want your colleagues to continue with the maternal resuscitation effort throughout. Unfortunately, the outcome may not be good all the time, as I was referring to from various national reports. So just to recap again, we've come back to what we would take as a structured approach in pregnant and non-pregnant would be exactly the same kind of structured approach. But only thing that is different is what could be different just because the mother is pregnant, and what that baby is doing inside her. Is that baby, does it need delivery? That is another. That's the only additional thing I would say for trauma that you need to consider, really. So in general, we talk about 4 H's and 4 T's when we are dealing with pregnant mothers who may have had trauma. For this instance, when we're so 4 H's, we talk about hypoxia, hypovolemia. As I said, it can be quite concealing sometimes and can be difficult to pick up. These metabolic disorders may not be relevant when you are talking about trauma patients, but maybe later on once you have stabilized the mother. And then hypothermia, obviously, that is extremely relevant right at the start. And then when we're talking about 4 T's, we talk about thromboembolism because in general, when you're pregnant, you are more prone to develop a clot. And also what is new in when you're pregnant is you've got this bag of fluid in your uterus, which is inside a sac, very safely inside there, protecting the baby. But unfortunately, when there is a sudden accident, sometimes the little embolus of that fluid can get into your veins, and that is what we call as amniotic fluid embolism. That is really what we never want to see, because unfortunately the outcome is not very good when there is amniotic fluid embolism. And many a times it can be a diagnosis that we can, definitively find when we by postmortem. So it is not nice. And one case where I was involved in maternal death was a case of amniotic fluid embolism. So it is really one unique thing that can happen in pregnancy. And because of that acute effect on the uterus, if there was any direct compression, then that is one thing we need to keep an eye on. Obviously, there's no different way of managing it. It's again, same structured ABC approach, but it's just something that we need to think of as a possibility. And the other things obviously is the toxicity, which may not be relevant exactly when you're dealing with trauma, but it's more something that we teach our colleagues and our trainees when we are doing procedures on labor ward if the mother collapses. And then there is the tension pneumothorax and tamponade. So these are the 4 HS40s. We always remind ourselves to think of this, to find the specific cause, because how you would manage would be sometimes when you come down that structured approach, you may want to come to that definitive intervention fairly soon, and this will help us get to that if we are thinking about a specific cause. So what about the baby? As I said earlier, the best treatment for the baby would be to resuscitate the mother adequately. So only when there is mother who has had a life-threatening injuries, if you think the baby is, you don't worry about the fetal viability at that stage. You just have to deliver the baby and concentrate on your mother. As I said earlier, fetal heart rate abnormalities can be often very, very obvious quite early on. And that is what we as obstetricians look for to find out causes for hypovolemia, especially in this scenario, and to intervene if that is what is found. So as I mentioned earlier, so the amniotic fluid embolism and severe pulmonary embolism can be specific complications which can happen in pregnant population. The treatment is again supportive, and you might have your mother going to DIC, so you may need to deal with anticipated hemorrhage. You may need to consider early delivery, and you will definitely need help of your MDT team, including hematologist, etc., to manage this mother effectively. Similar thing holds about pulmonary embolism. Again, the reason why it is important in pregnancy is, as I said, there can be a prothrombotic condition going in your blood when you're pregnant, and hence having a pulmonary embolism can be, it has to be one of your top things that you think about when you're dealing with pregnant population. So once we have thought about what is happening, what are the 4 HS40s in your brain, and you're thinking possibly this is what is happening, that's when you need your senior clinicians already, or hopefully are all already involved. You need that kind of communication between the members of the MDT. And if you're in a unit where you're not able to support, you may need to arrange that transfer ASAP, and you may want to make sure that you have a clear handover. That's when we use a few kind of mnemonic or something which we use very often in obstetric emergencies, basically, where we talk about a structured handover. So I'll come to that in a minute. So we usually use what we call as a S-bar, which a lot of you may be familiar because it's something that a lot of us use actually. But then what we talk about is what is the situation, what's the background assessment, and what you think you want to do for this pregnant mother. But more specific for trauma, for the pre-hospital transfer, in the MOE courses, we talk about what we call as a ATMIST, as a mnemonic. to make sure that you've given all the information that your receiving team has got. So it stands for age and what is the gestational age of the baby, and what time did the trauma happen, and what is the estimated time of arrival, how did the trauma happen, what injuries can you see obvious. Sometimes, as I said, you may not actually see anything obvious, which is one of the cases I was mentioning earlier, where actually mother did not have any bleeding anywhere. Nothing was obvious after a trauma. She was, initial primary survey was all passed. But then when she came in here, we found that there was concealed hemorrhage behind the placenta, which could have been life-threatening if we did not recognize that. And then obviously what your signs are, what are you seeing, and then what treatment have you done already before the transfer. So we cannot finish this talk without talking or touching on human factors, because all of us come to work with our own kind of baggage, if you like. And in the one case that I was telling you, we had a midwife who was actually probably not feeling herself that day, and we had to actually know that by working with her, because we had to actually kind of intervene and overcome what she was doing, or just something like that. I mean, all of us have got our own bad days or good days, but we just need to keep this in the back of our mind, since to say to voice our concerns if that is what we think needs to happen. So it's just obviously there's not a human factors lecture, but it's something that we need to always keep in mind, because in obstetric emergencies we always talk about human factors. We had a registrar who arrived late. I just put that big line of cars there because she arrived late to hand over. And when she came in, we were in the middle of an emergency. We were dealing with it. And obviously she came in rushing to the unit, looking at her clock, thinking, oh, I'm already missing the handover. And then just imagine the flight she will come in to deal with this mother who needs resuscitation. So I think these are the things. Obviously, you would not want her to be the first person leading the team at that time. So I think these things you need to just keep in mind when you're dealing with a difficult scenario like this. Again, just to summarize, I know I'm nearly out of time, but just follow the usual survey structured approach that you would do with any population, any trauma patients, but then just think about the implications with the fetus being inside, really. So you would just follow the same summary as you would do in non-pregnant, but then think about, is the baby affecting your outcome? If yes, then you need to intervene. So that's, I think I just rushed in the end, but I will stop there so that we have a few minutes for questions if anybody has any questions.
That's perfect. Thank you very much, Reddy. It's really